our bi-monthly in-service. Dr. Priya Thomas will be discussing pregnancy and spinal cord injury. And if you can mute your mic, that'd be helpful. Thank you.
Hi, colleagues. Thanks for being here. We can go ahead and get started. So my name's Priya. All of you probably know me by now. I'm second year here, now in the spinal cord injury service, in the physiatry residency here at University of Pennsylvania. I'm really excited to talk to you today about the intersection of pregnancy and spinal cord injury. I thought that this would be uniquely relatable, of course, for me, most of you knowing that I had a child this year, and particularly to highlight the challenges that this population may face, and touch on strategies for support for these folks. So this particular topic is designed to be more of a macro level introduction into the intersection of these two worlds. Okay. So from the top, talking about spinal cord injury and understanding that before we talk about pregnancy and spinal cord injury together, most of us know by now, but I just wanted to do a brief overview of spinal cord injury. So this is any type of injury or damage to the spinal cord that can result in partial or complete loss of motor and or sensory function in the body. We mainly classify spinal cord injury into two larger classes, complete or incomplete injuries. And today I won't get into the nuances necessarily of all of the ASIA testing, which is the further delineation and stratification of classifying spinal cord injury. But that's something that I believe we're all at least have nuances of or are aware of. So most common causes we see are traumatic events. And so this can include falls, motor vehicle accidents, crashes, sports injuries, and the like. There is a global prevalence of spinal cord injury, and so this is not, of course, unique to the US or our local population, but really is more of a global topic to consider. So according to the Brain and Spinal Cord Injury Trust Fund Commission, 80% of spinal cord injury patients that are afflicted with spinal cord injury are male and 20% are female. So it's really a 4-to-1 ratio. So females are less likely to have spinal cord injury, less associated to have spinal cord injury. But knowing that the highest per capita rate of injury occurs between the ages of 16 and 30. And so while those are predominantly males, we still have females to consider at this age, which is prime childbearing years, more so societally and socially acceptably on the latter half of that stage, but still as young as 16 potentially. For statistics, the average age of spinal cord injury tends to be around 42 or 43 years of age at this time, with the median age of injury being 26, but the mode or most frequent age of injury being 19. So really in those prime childbearing years. According to ACOG, which is the American College of Obstetrics and Gynecology, there's approximately 17,730 new spinal cord injury cases per year in the US alone. And nearly half of those are occurring between the ages of 16 and 30 years old. Okay. And I wanted to show a graphic. I'm a very visual person about what anatomy looks like in spinal cord injury. Most of us are familiar, but I wanted to touch on, starting with the top left, some sagittal views of our spinal cord and vertebral column with our intervertebral discs. I'm not sure if you can see my mouse. Sorry if you can't, but we have our
we can see it.
Okay, perfect. We have our intervertebral discs along the vertebral bodies that separate our vertebrae and our bones. This is our spinal canal, which our spinal cord is housed in. You can see a lot of supporting bony structures, right? Supporting our most vital nerves in the body, connecting the brain and the rest of the body to the spinal cord. So here is another nice cross section we have here of the butterfly, which is the orientation of our spinal cord. We have our gray and white matter in here in our butterfly orientation and surrounding. Then we have our nerve roots exiting through the foramen, innervating the body and spreading out in a fashion like so here. So from the brain down through our most caudal section and our sacral spinal cord. we can see how the rest of the body is innervated in our dermatomal and myotomal patterns, although I don't have a photo of it here. So when we talk about spinal cord injury, we're talking about damage that on imaging can present as in this T2 sagittal stir image we have on the right here, taken from Radiopedia, which is a great website to demonstrate more radiological findings. And so here you can see we have a cervical injury. This particular case highlighted was a central cord syndrome, which may happen in younger folks, but is actually more associated with the more elderly and happens from a hyperextension injury of the neck. Okay, so to talk about my personal interest, I just wanted to touch on my experience with the service as a whole right now. I think in my experience with the spinal cord injury service here, there has already been one female of childbearing age that these conversations pertain to. And while these patients' spinal cord injury and pregnancy, the interlap may not apply to everyone, I think it's important to talk about one, sexuality with these folks. The psychological component of being fully sexually functioning, having the ability to have children, whether that's with a female or a male, if there is spinal cord injury within the relationship. I think these conversations are really important to understand how to support this population. So it is in fact possible to have a healthy and happy baby. And so let's talk about it. Planning is crucial. So in the perinatal period, the care team should really be established. So the care team would hopefully consist of all of the following: a primary care physician to really help connect folks and be a starting point for talking about family planning, a physiatrist specific to spinal cord injury and the nuances related to its care, a rehab team that is comprised of therapy and nursing that can support the patient throughout pregnancy and even through birth, someone that ideally has a connection already with the patient and can continue that longitudinally. More importantly, we also have an obstetrician that would come into the picture, a maternal fetal medicine physician as well that deals with complex obstetric cases. And things to think about: a lactation consultant, probably closer to labor and delivery and anticipating the actual baby and how to care for it. We also want to consider folks like a neonatologist, although my inclination from the literature review I've done is that this is maybe less sought after as opposed to the other specialties. And another important one that can be overlooked at times is an anesthesiologist, to really help guide what labor and delivery looks like and what is safe for a woman with spinal cord injury. So prior to becoming pregnant, women with spinal cord injury should have a pre-pregnancy evaluation with their obstetrician of choice. There may be other studies and workup involved, such as PFTs to better evaluate respiratory status going into labor and delivery, renal and urine studies if they are plugged into a urologist. It's also a good idea to have a continuous relationship with urologist, as is recommended for anyone with spinal cord injury. Okay. And along with planning, in the beginning, you really want to start to talk about support system and resources, along with establishing a strong, robust, and thorough care team that can follow throughout the length of pregnancy. It's important for people, women with spinal cord injury, to be aware of what resources are available to them. So we, within the healthcare field, are their biggest resources, right? To connect them to reputable, verifiable, and good places to go for information and for support. So there's a few PDFs and online resources I found that would be nice, and I'm happy to share them if you'd be interested. But these are the things that we should be encouraging them to look for. So we would want the specialized spinal care clinics that's related to the medical professionals, really, but peer support networks connecting these women with folks who have been through pregnancy before a spinal cord injury can help decrease the burden and isolation that they may feel. We want to encourage some educational workshops and seminars, although logistically, I think that time may be a factor, especially with all of the upcoming appointments that maybe were not a part of their chronic spinal cord injury care may start to clash with that. It's helpful if they can attend something with that and see folks in person that are able to help connect them and support them. Online forums and communities going along with peer support networks, online or in person, right, in the community or online, support from all aspects is important. And then research guides and brochures, online resources are abundant at this point in time. Like I said, I'm happy to share some that I found. There's quite some literature online that's available through ACOG or through spinal cord injury websites that are very helpful. Okay, so we can talk about the effects of pregnancy on spinal cord injury now and move into what pregnancy actually looks like in women with spinal cord injury. So, um, during pregnancy, there are several hormonal shifts that physiologically occur as they do in patients without spinal cord injury. That doesn't really change or isn't necessarily heightened as a result of spinal cord injury. Changes in hormones such as estrogen, progesterone, and so forth, those are present with these women. But unique to women with spinal cord injury, if you're going to become pregnant, there is increased risk of spasticity and tone. And so that needs to be discussed and managed. And these patients need to be counseled for that as well. Regarding mobility challenges that may arise, weight gain, fluid retention are expected side effects and common with pregnancy. This, along with the disproportionate distribution of weight that's possible in women with spinal cord injury that have assistive devices and have needs for transfers involving, maybe unbalanced proportions, this can make it even more challenging. And so practicing and anticipating these transfers, practicing them with local support that can be in the home with them, can help them kind of acclimate to the changes occurring in their body. Along with the mobility challenges, there's also the natural laxity of joints that comes from ligament stretching that can make normal functioning more painful if there is sensation with women with spinal cord injury, and more effort is potentially required to prevent injury and pain. More consideration should be taken regarding augmentative devices that can help relieve those pressures. So, for example, pelvic bands may be an example that patients may want to use, but you have to understand the nuance of sensation changes. If the patient cannot sense that it is too tight or it is too loose, those patients that are at higher risk of complications as well. And regarding the bowel and bladder management complications, so as the fetus grows, as the uterus grows with these women with SCI, patients may need more frequent catheterization with their bowel regimen. They also are at higher risk of constipation, but also diarrhea as a result of pregnancy, and may have to adjust their bowel program accordingly. One more complication or effect of pregnancy I wanted to talk about on this slide is potential falls with the mobility challenges. And current adaptive equipment that they have, such as wheelchairs, that fit and stability may start to change over time. And so anticipating maybe needs for loaners or more temporary solutions to get them through pregnancy more comfortably and safely is a conversation that should be had with the care team as well. Okay. Accessibility is big. We're in such a large city, right? The sixth largest city in the country. It's a huge urban population with a wide variety of patient needs. And so accessibility has to be talked about here from the social perspective. So there are patients that have logistical concerns, financial concerns, right? Transportation concerns that only get amplified as we expand the care team and ask these patients to see more providers and physicians. So So that has to be hopefully coordinated if possible with different elements and different persons within the care team. If a patient can have, 2 appointments in a similar location on the same day, that can greatly decrease the burden and stress that they feel with the pregnancy. That overall contributes to their well-being and their mental state as well. And we can talk about the psychological piece a little bit later. So with the distribution changes with the weight gain and not urinary retention, sorry, fluid retention, patients and women with SCI have an increased risk of pressure sores as they become pregnant. Managing healthcare appointments can be challenging. And so we can do what we can to help them mitigate the need for frequent visits if we can. Okay. And all of these experiences, these side effects, potential complications, when patients are educated, it becomes easy to see that this task can be daunting, but it is doable. And so wherever, we're able to intervene in that process of pregnancy, social resources to offer are paramount to their continued care. Okay. And I wanted to touch on the physical and mental health considerations as well. So in a 2016 Switzerland study, it was demonstrated that women with SCI had some pregnancy complications, most commonly related to dysreflexia, autonomic dysreflexia, spasticity, as we touched on, the urinary complications, which we touched on as well. Also thrombosis, there's an increased risk of clots, DVTs, particularly in these women, pyelonephritis, along with urinary complications, pneumonia, preeclampsia, and preterm labor as well. So all of these things kind of inform the patient's decisions to move forward with care and make decisions in their day-to-day life. It's really important for me reading these statistics to recognize that these patients still have their own plans. They still have their own wishes, right? They're people first and foremost that we have to take into consideration what we want and have shared decision making to understand how we can get them to where they want to be with their pregnancy and their birth. Okay. Mental health considerations. I don't have a ton of data on this element. I can say the most common complication that I saw, the most common effect of particularly the postpartum and delivery area is the postpartum depression. There was a high prevalence of postpartum depression that I saw, followed by the need to screen for postpartum blues and postpartum psychosis, standard as we would in a woman without SCI as well. Okay. Now we get to the point of labor and delivery, what we would expect to prepare for. So in preparation for labor, as a woman with SCI is nearing the end of the 3rd trimester, you want to counsel them on warning signs, right? Because the sensation and the motor function may not be there for patients to tell you what's going on. And so we want to monitor for early signs of labor, including water breaking or a bloody show. So the sensation of fluid or blood coming from the vaginal area, right? The sensation of contractions is possible. Vital changes we want to be particularly careful of with blood pressure and concern for autonomic dysreflexia. This is at highest risk in women with SCI with neurologic levels of injuries, T6 or higher, but it still is possible, of course, in NLIs or neurologic levels of injury below T6 as well. It's always good to keep a high index of suspicion for autonomic dysreflexia if there are vital sign changes. And then when women with SCI design their birth plan with their OB, with their FMM physician, not so much within the rehab space, but still pertinent to our care, there are different options available. Right. They have the options that women without SCI do. There is a vaginal birth that's possible, a cesarean delivery as well. But a vaginal birth is healthy, possible, and preferred, recommended by ACOG. So considerations for women with SCI that are pregnant. They may not be able to actively push the baby out in labor, right? So clinicians, what I've seen that protocols look like right now is clinicians, OB folks actually rely on gravity to passively allow the fetus or the baby to pass into the birth canal. And then from there, positioning can help the baby kind of move further south, inferiorly towards the vaginal opening. We may have help from support people in the delivery room with helping hold legs up in stirrups, helping turn on sides, helping a patient if they want to deliver, on all fours and help gravity, help the baby out that way. That positioning is possible as well. So you may need, hospital equipment, you may need external personnel, and also the hospital staff assisting there. If the pregnancy is not able to progress, if the labor is not able to progress, there is assisted pushing that comes into play as well. So that's the term used when physicians actually use vacuum extraction or forceps to help assist the baby gently out of the birth canal. If none of those are really aiding the patient in having a vaginal birth, or if there are other concerns that are obstetric or related to the fetus, the health of the mother and the health of the baby, then a C-section can be pursued at this time. And talking about labor, I want to talk about pain management with regard to women with SCI as well. So for these pregnant women, the most preferred option that I saw for anesthesia for these folks is an epidural. Um, Spinal anesthesia may be used as well, particularly in higher level injuries. And then there is also the possibility of natural unmedicated births. Epidural and spinal anesthesia in particular have a beneficial role in preventing autonomic dysreflexia. So in this case, anesthesiologists can adjust the amount of epinephrine in the anesthesia to better match the dysreflexia risk of the patient related to the level of injury and the completeness of injury as well. And women with pregnant women with SCI in labor, if their neurologic level of injury is above around T10, they may not feel labor pain or contractions. And so one of the devices that they can use at home to detect these better is a home contraction monitor, and updating their OB regularly with that if there are any concerns. Okay. Post-delivery care is as important as the rest, right? We want these women to rest, recover, and have as safe a recovery as possible while also mobilizing them and preventing further complications related to spasticity, clots, orthostatic hypotension, and the like. Another consideration here is lactation consultants can be brought in to help with breastfeeding, and I'll talk about that in a little bit here too. So in the acute postpartum period, dizziness is really common, related to orthostatic hypotension most often. And so TEDS or an abdominal binder can be considered in the acute setting, as well as practicing safe transitions and transfers from the bed. Okay. Here, along with those things I just mentioned, we want to talk about perineal care right after just giving birth, if it's vaginal, or incisional care if it's a C-section birth. You want to keep a close eye on vitals, make sure that pain is controlled if there is that sensation there. And within limits, mobilize these patients early to prevent those complications. In this immediate period, you may want to consider a Foley catheter if patients cannot be cathed comfortably during this time with all of the changes in the genitourinary region. It's designed to come out as early as possible, of course, but can be left in for a few days without any concerns. To prevent straining and further pelvic floor pressure, you want to optimize a bowel regimen for them so that bowel movements are soft and patients are not straining. It's not as customary from what I've seen, but the option exists to have heat lamps available for patients with episiotomies. That is not recommended in women that do not have the sensation in the genital urinary area to be able to tell if their skin is burning, right? Because no one's going to be able to monitor 24/7 unless there's a external support there for the patient. Secondly, lactation consultants can demonstrate here in this arena how to breastfeed. They may need more physical support with these patients and learning how to manage breastfeeding, but it is possible and it is a natural occurrence that is expected.
Attention, please. Attention, please. The Good Shepherd Femme Partners Ice Cream Social is being held right now in the main lobby.
Yeah, hopefully you can still hear me. Moving into the first few weeks
The Good
postpartum,
Shepherd Femme Partners Ice Cream Social is being
you
held
want to
right now.
maintain a high vigilance for
Thank you.
postpartum blues, depression, psychosis. As I mentioned earlier, it's really important to get plugged back into the care team early. The OB team, the spinal cord injury physicians, the primary care folks, even although lower on the totem pole to plug in and see how these patients are doing immediately post-op. And then at home, once these patients discharge home, lactation consultants are available to come to the home. And so milk production can tend to decrease after 6 weeks postpartum for patients with a neurologic level of injury above the nipple line, T4 to T6 even, because that sensation loss is needed for breast milk stimulation. And so lactation consultants can work with these women to work on relaxation. There's even oxytocin nasal sprays that can help folks maintain their milk production, and mental imaging as well, or time with the baby to help promote that flow and breastfeeding ease. Okay. And throughout all of this, I wanted to emphasize the attention to the psyche at this point with these folks. It is a unique experience. It's a uniquely challenging experience to deal with chronic spinal cord injury, or even in the acute phase if a patient becomes pregnant. And so while we may be plugging these patients into the appropriate arenas, it is also our due diligence to check in with them ourselves as their primary caregivers in this time, or as their external supports if we know someone that is pregnant with spinal cord injury, and help out where we can. Okay, that brings us to the end. So my takeaway points here are, along with the medical information I shared, to emphasize how important education and support are in caring for these women with spinal cord injuries in their endeavor to be pregnant, have a healthy and happy baby, and do so in a way that doesn't sacrifice their physical and mental health more than the natural physiologic changes. Okay, I know I'm a little over time, so thank you so much for being here. Here are my references. I'm happy to take any questions if there are any, or comments.
Thank you, Priya. That was excellent, very thorough. I'd love to hear the questions from the group. Certainly somebody has to have a question. So how do you think you advise like OBs or patients that they're like, oh yeah, we have my OB is recommending a scheduled C-section, 3 months from today. Not sure how I feel about that. What would you say to the patients? What would you say to the OB? How would you kind of advise them?
Yeah, that's a great question. And I'll speak with practice, which uh, to provider, right? What are the risks and benefits of both? Why are they recommending a C-section in this case? Is the patient very aware of their chronic spinal cord injury, very literate from a health perspective to to have those conversations and maybe sway the decision elsewhere if it's warranted. So I think the answer to that question is multifaceted and a gray zone, but it starts with communication with your providers and really advocating for what you want as a patient. I think that we can touch on risks, risk and benefits of C-section, but ultimately that would be up to the OB team.
Yeah, I think a lot of times like they're just kind of defaulted into C-section because it's in some ways easier. And, they don't really necessarily have that conversation. I think there's a role for us as, physiatrists to talk to our OB colleagues and have like a partner there that, when a lot of times the patients will talk to us, prior to getting pregnant, and we have like, who should I see? And, really honestly, now I say, well, see maternal fetal medicine because they have a little bit more expertise in these more complicated situations and potentially a little bit more time to kind of address them. But it becomes kind of, you hear that a lot of the patients just kind of go straight for the C-section, I think, a lot of the time.
And easier is not always better. You're right. I think there's more of a chance that we can advocate for our patient and help them advocate for themselves if we are able to establish contact from a provider level as well. So I echo that sentiment. Thank you.
And what would you say to your patient who's like, what should I do? Like, not necessarily in terms of the communication, but like, doc, should I get a C-section or should I get give natural birth? Well, not natural, but, vaginal.
Yeah. I mean, I think that if the pregnancy is healthy and there aren't any risks to pursuing a natural birth, I don't see why not. I think there is, increased difficulty, potentially, especially with higher level injuries, where that sensation, that motor loss is going to make things difficult, I think, from a care team perspective in the hospital, but I wouldn't counsel against it necessarily.
Great. Thanks so much. Any other questions? Well, once again, thank you, Dr. Thomas. As always, these in-services will be available to review or for your colleagues on our YouTube page. Thanks again.
Thank you, everyone.